Welcome everyone to this year's Oppenheimer-Ginsburg lecture. Very special event that's been held every year since, I believe, 1987. So it's going on for more than 30 years. According to ancient records, the first inaugural lecture was Sidney Truelove, actually, and later Henry Janowitz, Arthur Ausfus, Ted Bayless, who just passed away a short while ago. My mentor, Dan Podolsky, Lloyd Mayer, Steve Hanauer, Balfour Sarter, Steph Targan, Dan Present, on and on and on. Many luminaries have come to deliver this Oppenheimer-Ginsburg lecture. So, but there are some here who may not know who Oppenheimer and Ginsburg were. Every year I like to reintroduce people to who these people were and what they did actually. So these are their pictures. I have it confirmed by jury that I have them labeled correctly this year because I never met them myself. But their story is this. Gordon Oppenheimer was born in New York City in 1900, and he got his bachelor's in medical degrees from Columbia. And then he did a 2-year internship at Mount Sinai Hospital, completing it in 1924. And then during World War II, he was second in command of the General Surgical Service at Mount Sinai Hospital. During his lifetime, he served on the staffs of Bronx Hospital, Gouverneur Hospital, Sydenham Hospital, and Mount Sinai Hospital, of course. He became the director of the Department of Urology at Mount Sinai in 1947, and he stayed in that capacity until 1963. And in 1971, after leaving the private practice of urology, he became chief of the VA Regional Office Outpatient Urology Clinic, and he did this until 1974. While Dr. Oppenheimer made many outstanding contributions to medicine and the medical literature, perhaps his most outstanding contribution was his work on regional enteritis. He was a member of the original team that delineated this important condition. In fact, it was Dr. Oppenheimer who worked in the laboratory and did the pathological description of the disease. He published 69 separate contributions to the medical literature, and these range from urological subjects as well as basic science work and his work on regional enteritis. And the other gentleman, natty guy, Leon Ginsburg, was born in New York City a little bit earlier, 1898. He received his bachelor's and medical degrees also from Columbia. He served on the house staff of Mount Sinai Hospital and became an adjunct surgeon in 1926. And then in 1937, Dr. Ginsburg became an associate surgeon at Mount Sinai. He remained on the hospital staff throughout his career, and in 1940 he became surgical director of the Harlem Hospital. In 1942 he joined the staff of the 3rd General Hospital of the U.S. Army unit affiliated with Mount Sinai. He also served in North Africa and Europe and eventually reached the rank of major. In 1947 he was appointed director of surgery at Beth Israel Hospital in Manhattan, and he served there until 1967. As an adjunct surgeon at Mount Sinai, Dr. Ginsburg served under the eminent surgeon Dr. A.A. Berg, who charged him and Dr. Oppenheimer with reviewing surgical specimens in the pathology laboratory. Ginsburg and Oppenheimer developed an interest in diseases of the bowel and began a project to describe and categorize their specimens of bowel tumors and strictures. Of the 52 specimens they examined, 12 did not fit any previously described patterns that were known at the time. And at Dr. Berg's insistence, Ginsburg and Oppenheimer shared their research in a draft paper with Dr. Burrell B. Crone, an internist who had been collaborating with Dr. Berg on the treatment of 2 patients with similar conditions. Dr. Crone made additions to the paper, and then he presented it to the May 13th, 1932 meeting of the Gastroenterology section of the AMA. The paper was later published in the October 15th, 1932 issue of JAMA. As Dr. Berg declined to be listed as a co-author of the paper, it was published under the alphabetically listed names of Crone, Ginsburg, and Oppenheimer. Dr. Ginsburg, meanwhile, had presented a paper on his and Oppenheimer's findings to the AGA on May 2nd, 1932. Note that that was at least a week earlier than Dr. Crone. This paper was eventually published in the 1932 Transactions of the AGA under the title Nonspecific Granulomata of the Intestines, and expanded in form to the December 1933 Annals of Surgery. And these papers introduced the diagnosis of terminal ileitis, which was later called regional ileitis, eventual regional enteritis. And due to Dr. Crone's activities in presenting the diagnosis to a wide audience, and the fact that his name was first on the paper, Crohn's disease became the name by which regional enteritis was commonly known. And Oppenheimer and Ginsburg, I'm told, often joke that they were known as Et and Al. So it's in their memory that we recognize their very significant contributions to the field of IBD, really seminal contributions. Crohn, of course, also did contribute in his own way. And therefore, it's a very illustrious group of prior speakers that Dr. Sonia Friedman joins today. And Sonia, I've known, I guess I have to say, since she was a fellow, because I remember when she was maybe a third-year fellow, I was invited here. I was maybe 4 years on faculty at Mass General, and I was invited to participate in a panel discussion, I think with Bert Karlitz and Dan Present, and I was the young whippersnapper. And I remember she made the cases, which were extremely difficult cases, and I remember being very anxious about this because it was not just delivering a talk, but responding to her very difficult cases. So I've known her since she was a fellow, and of course when she moved up to Boston, she was a colleague across town at Brigham and Women's, where she's been ever since leaving here from her GI fellowship. Before that, her bachelor degree was from Stanford and MD was from Yale, and then she and I both shared, not at the same time, medicine training at Hospital University of Pennsylvania. And she's risen through the ranks at Harvard Medical School to associate professor now for a number of years. She lectures internationally, she's widely published, and she's best known not only for her excellent, really superb clinical care, but also for her approaches to fertility, sexuality issues in men and women with IBD. She's the director of women's health in the Crohn's and Colitis Center at the Brigham and Women's Hospital. She published in 1998 with Henry Janowitz on amyloidosis in the GI tract, I guess while she was a fellow. She currently is funded by a Crohn's and Colitis Foundation Senior Research Award, doing work using data from the Danish National Database with Bente Norgard. So it's funded research and very interesting stuff that maybe you'll touch upon. So it's truly a pleasure to invite and welcome back Sonia Friedman.
Thank you. Thank you.
Let me eliminate this for you. Okay, now the old guys go away. And there you go.
It's really, really an honor to be here. I really want to thank everybody and Bruce for inviting me, and thank you for that really nice introduction. Today I'll talk about reproductive health in 2019 and some of the stuff that I've been doing. So I just wanted to start with, I don't know, many of you remember Dr. J. This was, I was his last fellow, so I really had the privilege of working with him for 3 months, and I just want to do a shout out to Dr. J. So if you look at the timeline of reproductive health and IBD, there's a lot really to do research on. You have maternal IBD, paternal IBD, so there's all the genetic studies, and then the ability to conceive, the in utero period, neonatal, etc. So where has research been done, and what more do we need to do? So in terms of the ability to conceive, there's so many factors. There's sexual function in men and women, and there's been some research done on that in IBD. Sperm quality in men, which is actually a new field, and there's been some Danish research on that. Fertility, which is so hard to measure. There's been some preliminary studies, and I'll go over some in vitro fertilization studies that I've done in women with IBD. There are a few studies of safety and medications at conception. There's been a lot done in women, but not a lot done in men with IBD. And then the efficacy of in vitro fertilization, because more women with IBD, at least, need IVF. In terms of the in utero period, we don't have a lot of early pregnancy outcomes. There's one paper on ectopics that an attending I work with did. Elective abortions, we did a paper on that, and we actually showed that women with IBD have fewer elective abortions because their babies are more precious, we think. Spontaneous abortions. How about the safety of medications and disease activity during pregnancy? Well, there were just AGA guidelines that came out, headed by Uma Mahadevan at UCSF, who was an ex-resident here. She did a lot of studies on gestational weight gain. There's been some controversy on mode of delivery studies. In the neonatal period, what to think about, adverse birth outcomes. We have a lot of those studies from women. Not a lot, and some studies in the biologic literature and acute childhood infections, mostly acute infections in women who used anti-TNF medications during pregnancy, and then safety of medications during breastfeeding. But what about childhood, adolescence, adulthood? There really is not much on women and men with IBD and the long-term risk of disease, the long-term risk of medications given for the disease. There's really no studies on that. And then what about motor and cognitive development of children exposed to IBD itself and exposed to medications in utero? And adulthood pretty much is the same thing. We don't know much on the risk of chronic diseases, on the children of parents with IBD, or the risk of the long-term medications received in utero. So there's a lot to be done. So for your consideration today, I'm going to review kind of the early stuff with men and women, the ability to conceive, sexual function in men, sperm quality, fertility in women and some of the IVF studies that we've done, the safety of fathers' medications at conception, and the efficacy of in vitro fertilization in women. So look at these in terms of men's health. Thinking about men's health, look at these 4 things. How do they relate to each other? How do they relate? Sperm quality, birth outcomes, long-term birth outcomes, long-term outcomes, fertility, and sexual dysfunction. Relate to each other at all? There are a lot of papers that combine 2 of those. So are any of these related in men with IBD? So let's take a look at sperm quality. There's a lot of things that can affect it. Smoking, environmental or chemical exposures, and Russ Hauser at the Harvard School of Public Health did a lot of studies on diphenolphthalate. You'll remember it used to be an ingredient of Azocol and Azocol HD, and found that it did affect sperm. Different medications. What about IBD medications? Do biologics, do thiopurines affect sperm? And then does a disease activity, really active disease, have some kind of effect? And does this then affect birth outcomes or long-term outcomes of the child? So it probably is connected. Is sexual dysfunction connected to fertility? Well, yeah, obviously it is. Is sperm quality affected to fertility? Well, it kind of depends on the method you use to measure sperm quality. There are 3 different types of methods. The traditional method, I'll go over it a little bit, is the WHO method. That's basically a microscopic method to look at sperm motility, and it doesn't really correlate that well with fertility. Then there's a DNA fragmentation, which correlates a little bit better. So there's a big question mark there. A lot of studies try to link sperm quality with fertility, but it's actually kind of difficult. It's not that clear. What about sperm quality and sexual function? Not really at all. Not really at all. And a lot of people have tried to link that, but there's not really any connection there at all. So what about men's health overall? I just wanted to start with a study that I did. I've been really, really honored to work with Bente Nørgaard, and she's Chief of Clinical Epidemiology at Odense University in Denmark. So we've done some studies with the Danish National Database, and we wanted to look at sexual dysfunction in men with IBD, because not a lot had really been done about it. So the codes weren't really great in the database for looking at sexual dysfunction. So what we did is looked at medications for erectile dysfunction in men with IBD. So our study population was a Danish cohort, men 18 or older, and we looked at men with IBD versus men without IBD. And we controlled for prescription medications. We also controlled for psych meds and meds that affect the CNS. And we actually found that men with IBD do use more medications for erectile dysfunction. That's regardless of whether they have UC or Crohn's and whether they've had surgery. It all pointed to increased medication use. So we concluded that men with IBD have an increased risk of erectile dysfunction. So now that we know it's there, the key is to find out really why and what we can do about it. But the first step really is to ask your patients. Ask your patients about sexual function. We really find that it's really not discussed in clinic at all for men or for women. And I'm just going to go from the male aspect of this because of time factor, but I do want to show you just a little bit of research we've done with asking men about sexual dysfunction. We started doing this about 5 or 7 years ago We had an idea where this is really not talked about at all in clinic. And we think it's really important to these people because they're young. I mean, these are young patients in the peak reproductive years. And they're really thinking about, you'll be shocked if you just start asking them sexual function, fertility, pregnancy. These are concerns really on everybody's mind. So we basically, we did a sexual dysfunction scale specific to IBD. The sexual dysfunction scales before this were really generic. They were in the one that was used in all the studies of prostate cancer and chemo and which was the International Index of Erectile Dysfunction. And that was a really generic scale, and it wasn't specific to IBD because men and women have very specific issues. Perianal disease, surgery, ostomies. And these are really important. So what we found, but again, we couldn't compare it with a control population because this was an IBD-specific scale. But we found, we looked at 175 men, and we gave them the scale, which I'll show you in the next slide, and that we found that male sexual dysfunction in IBD was significantly associated with a pouch, which is not surprising. Depression is a really biggie in men and women for sexual dysfunction, and increased disease activity. And I'm obviously not going to read all these, but this was the scale we ended up with. And we validated the scale by comparing it to scales for depression, generic scales for sexual dysfunction. So we were left with a validated scale for sexual dysfunction, sexual function, and we have this one for men and one for women, and now we can use it in studies over time, and it could be incorporated into clinical trials of medications. It could be used to study sexual dysfunction over time. And I think Jordan Axelrod at NYU is thinking of doing a long-term study with this, as well as some other sites in New York, I think. So, but these are some of the questions, particular to men with IBD. And we have a similar scale in women. So what do? Well, first you have to ask. Most men and women say that they prefer to be asked. The doctor doesn't ask, and they're a little too shy to bring it up themselves. So the first thing you have to do is ask. And then it's good to check AM testosterone levels. And if it's less than 300, we refer. We also get free testosterone and sex hormone binding globulin to try and evaluate how low the level is. But if it's low, I don't know how to treat it. I usually just refer to urology. You also want to make sure they don't have diabetes or cardiovascular disease, obviously. Depression is a biggie, so you want to try and identify depression, and there's scales to do that. Control disease activity, obviously, and then obviously ask about a history of IBD surgery. For women, just as an aside, for women, just as an aside, if you find they have sexual dysfunction, a lot of it is dyspareunia or painful intercourse, and most of it, or a majority of it, could be fixed by pelvic floor physical therapy. So that's really a key thing. We have a really good therapist at Brigham, and we refer, women do get a lot better. But the first thing you guys have to do is ask. So I kind of want to move on to fatherhood and the effect of medications and disease activity on sperm and how it can potentially be passed on, which is kind of a new concept. We all think of, medications in utero affecting the baby. It's all the woman's burden, the woman's problem. In terms of the effect on the child, but really, men have at least 50% of the burden in terms of drug and environmental and chemical effect on sperm, and I'll show you why in a little bit. So this is Homer Simpson. I never thought of fatherhood as something that could affect a kid. So does fatherhood matter? What is the mechanism of a potential effect of IBD medications and IBD activity on sperm and subsequent birth and long-term outcomes of the offspring? So as you know, spermatogenesis takes 70 to 90 days in humans, and most of these studies use a 3-month cutoff because that's how long it takes the sperm to mature and develop, looking at the toxic effects of a drug on sperm development and thus the effect on the offspring. So there are different measurements of sperm quality, which I alluded to earlier. And you've seen this in some of the IBD studies. Saha's study on methotrexate and gastro, she looked at 6 men compared to a control population, and she used the SCSA assay, the second assay, and that's a little more sensitive than WHO. I think people are more starting to use the DNA fragmentation assay, which is a little more specific in terms of prediction of male fertility. And there's also something called the neutral comet assay that kind of predicts miscarriage. And I think most sperm banks are using a combination of these now, at least they are in Denmark. So this woman, Anna Grossen, I just was there for her PhD thesis in Aarhus, Denmark, and she did 5 years looking at sperm quality and the effect of medications on sperm quality. And you know why that's important? It has implications for fertility, it has implications for birth outcomes and long-term outcomes of the child. And she found some pretty interesting things. We all used to be worried, do thiopurines affect sperm? Do anti-TNF affect sperm? But it turns out they don't really, and she used both types of assays. The WHO, actually all three, the neutral comet and the DNA fragmentation. And she found that thiopurines were safe. They may impair motility, but they're safe. Infliximab and adalimumab do not impair sperm quality. She actually used in some of her subjects men in the hospital on IV steroids to get samples from them. And she said they were very willing if she just explained the study. I thought that was amazing. She's a very driven person. And she found that just severe active flares, and these were men just on IV steroids, it did not affect sperm DNA integrity. Sperm motility and testosterone levels, by the way, were impaired with disease activity, which would make sense, but they normalized during remission. So none of these drugs really had much of an effect, which is good. So this is from several papers in the literature that Russ Hauser has done a lot of research on this. What exactly is the insult to sperm? And this is kind of new learning for me too, which I thought was fascinating. You have somebody's environment or lifestyle. For example, diphenolphthalate and azokol, that's a good example for IBD. Or other IBD medications, toxins, endocrine disruptors, that's what diphenolphthalate is called, smoking, obesity. And the insult can occur during sperm development. And what it does, it has epigenetic effects. And what that is, it doesn't just damage the DNA. It is not just the potential to damage the sperm DNA, but it could damage it could affect gene expression. So there are other factors in sperm besides just the DNA. There's histones, there's microRNA, and these things can all affect epigenetics, which can alter gene expression in the zygote. So sperm really can affect the developing fetus. Also, semen outside of sperm also has factors which can affect the vaginal mucosa, which can affect the embryo, which can affect gene expression. So it's actually kind of a bigger deal than anybody thought. So the father really does have a great impact on the child, on the development of the child.
What's the word of methotrexate?
Methotrexate is safe. I'll show you some studies. So,
do people look specifically at the histone medications if there's any changes with these medications?
they haven't done that yet. So Anna Grossen looked at sperm quality by those 3 criteria, but she didn't do any complicated. Yeah, no. It's a theory, and if you look at research done, men with diabetes can pass it down to their children. Men exposed to toxins and benzenes and chemicals, the kids have a higher risk of leukemia. So, and also there's been animal studies done that have looked at that. So it's from various animal and human studies, and this is kind of the theory, and it looks to be true. So these are studies that I did with my colleague Betsy Norgard, and also some colleagues at Brigham who went over to Denmark and did research there, which was really nice. So we did papers on methotrexate, thiopurines, anti-TNF medications. We limited it to 3 months before conception, in that period where sperm are developing, to see if there was any effect on birth outcomes. And this is this is in the Danish studies. So I'll just show you briefly. This is Rachel Winter at my institution, and she looked at paternal methotrexate, men exposed to 3 months prior to conception. So we looked at, basically this is the Danish National Database, so everybody in Denmark gets a CPR number, which is a registry number, and you can link it to the mom, to the dad, to the kid, to the medicine, to the disease, to hospital admissions. You just know how to have to pick at all the variables with the ICD-10, and they don't have ICD-9 codes, ICD-8 codes. So you can actually look at all the stuff. You can look at moms and dads who got methotrexate, and then you can look, or 6-MP, and you can look 30 years later. You can look at the extent of the time limit of the databases, which is like 1995 for meds and 1977, excuse me, when it started, when the database started. So we looked at exposed children versus unexposed, and this is basically all the births in Denmark we were able to get versus exposed. So exposed was 193 children with various diseases, most with rheumatologic diseases on methotrexate. And we looked at preterm birth, congenital anomalies, and small for gestational age, and there was really no effect. So it was safe. It was safe in terms of birth outcomes. The same thing with anti-TNF. This was Michael Larson. He's inventing Norgard's group, and he did Remicade and adalimumab. They don't have Cimzia in Europe at all, by the way. So he looked at exposed versus unexposed, different diseases, IBD or rheum, birth outcomes, and again, really no effect on birth outcomes. Preterm congenital anomalies and small for gestational age were all about the same. So these things are very reassuring when you talk to your patients. And then we looked at 6-MP and azathioprine within 3 months prior to conception. Again, the same birth outcomes. So in terms of preterm birth, congenital anomalies, and small for gestational age, it was not significant. So this is the biggest study on 6-MP azathioprine out there. We had, I think, about 700 men. 700 men. So this is really reassuring to fathers. And we adjusted, of course, for the age of the mom, for the parity, for smoking, which they had in the database, for calendar year of birth, etc. So now this was a cute little thing that we did. We looked at the database again, I think it was about a year later, and we found 735 dads who were exposed to 6-MP again, and we attempted to look at long-term outcomes. Because the database started in 95, I think, and so you can look till the present day. The study was done in 2017, so we looked at 735 kids, and we looked at long-term outcomes, again, various diseases. It was a little tricky because there weren't a lot of outcomes. Now, the outcomes we looked for were malignancies of the children and also autism and ADHD, because that had been linked to IBD, autoimmune diseases. In the literature, there's some data which is linked to kids with IBD. So we wanted to look for that as well. But there weren't a lot of outcomes, which is wonderful. We don't want kids to have cancer. 1 child with leukemia, 1 child with ASD, schizophrenia, 3 with ADHD, and for the exposed kids, a median follow-up time of 6.7 years. These are the unexposed. So we couldn't really do analysis because the numbers were so small, but this is kind of a beginning to look at the long-term outcomes. So our results regarding the safety of paternal IBD meds within 3 months prior to conception were reassuring and don't show any increased odds of adverse birth outcomes. The long-term outcomes look good. These are the biggest studies to date, but there's more research to be done on this topic. So the future studies, which I find much more fascinating, are the long-term outcomes of the children of fathers just with IBD alone. Because IBD itself, somehow, does it affect sperm? Does it have an effect on long-term diseases, like chronic diseases? And you can look for multiple types of chronic diseases and infections in the registries, and malignancies. And if you just look at fathers with IBD on or off meds, that's a much greater population, so you have a better power calculation if you look at acute infections and these other things. And then we want to look at the long-term follow-up of the children of mothers who use these drugs during pregnancy. Because if you think about it, all the studies have been done, and I've looked at every single one, I think, are just on birth outcomes and short-term outcomes in the moms. So there was a French study, there was a Dutch study on women who used Remicade during pregnancy and the birth outcomes of the kids, and it was only up to a year, and they only looked at acute infections. There's very few long-term outcome studies because it's hard to do, and this is a really great opportunity using this database to do it. So that's kind of what we hope to do in the next round of things. So I do want to go over some of the fertility stuff just because I find it really fascinating. I find fertility and IBD really fascinating because there's so many things that affect it. So what we know about fertility, and I didn't have enough time to talk about the male aspect of fertility, and honestly, there's not a lot of research out there. It's kind of hard to do. Mostly it's measured by looking at sperm quality, which is not a great indicator of fertility, and looking at how many kids the fathers of IBD, fathers with IBD had. How many children did they have? What's the time between children? So they're not really great. How do you measure fertility in a population anyway? How do you measure fertility? How do you know who wants to get pregnant? I'll show you some kind of cute ways some British researchers did it in a little bit. So what we know, and this is kind of staggering, is that there's increased voluntary childlessness in IBD, and that's up to 17% of women. Estimates are around 14 to 18%. So 17% of women with IBD say they're not going to have because of their IBD. With men, it's less. And then IBD surgery decreases fertility, and that's usually proctectomy, anal rectal resection, and pouch, and ostomy, etc. What we are beginning to understand, the effect of laparoscopic surgery. People do better in terms of fertility with laparoscopic surgery and assisted reproduction on fertility in patients with IBD. We do know with several studies that patients with Crohn's have decreased ovarian reserve, and then patients with active disease, and there's only one study in patients with active disease, probably have decreased fertility. So I did want to talk a little bit about voluntary childlessness. And this is where I think like doctor-patient conversation is really helpful, because a lot of these people don't have correct conceptions about pregnancy or the effect on the child. Most of them need reassurance. People really have, and this is up to like 80% of patients have these fears. A fear of the effect of IBD on pregnancy and pregnancy on IBD. So talk to patients, tell them you want their disease activity to be in remission 3 months prior to conception. Tell them that biologics are safe. There's now AGA guidelines, right? You can show them the guidelines. There are patient websites as well, stating that all these biologics are safe, at least for birth outcomes. There's no data on long-term outcomes, okay? That wasn't mentioned in the guidelines. But anyway, the fear of infertility. People fear infertility, fear of heritability. They're afraid they're going to pass it down, and that is true to some extent. But you can allay their fears somewhat. It usually isn't as much as they think. Perceived negative impact of IBD medications on the course of pregnancy and fetal development. A lot of people are very worried about their meds. And this is an excellent center. Obviously, your patients don't go off their meds, but in a lot of other places they do. So what about ovarian reserve? The definition of ovarian reserve is the capacity of the ovary to provide egg cells that are capable of fertilization, resulting in a healthy pregnancy, and all the fertility doctors check anti-Müllerian hormone, or AMH. And that's actually lower in women with Crohn's, a little older, with colonic disease, with higher disease activity, with more disease duration. And if you start looking at this, you'll find that a lot of your patients have decreased ovarian reserve. The docs are checking it, the fertility docs always have checked it, but it's being checked more and more. So this was the only study that looked at disease activity and fertility. Now, fertility is a tricky outcome, right? So their definition of fertility was live birth. They didn't know anything about early pregnancy outcomes. They didn't know about people who tried and couldn't get pregnant at all. So this is, live birth. And this was in a UK primary care database, women aged 15 to 44, and they looked at time bands, and what they used fertility rate ratio, which is live birth. And they adjusted it for age, smoking, and socioeconomic factors, which you have to do, because people who don't have enough money might not want to have another child. And they actually excluded periods of contraceptive use. And so if you were on birth control, they didn't count it as attempting to get pregnant. And for disease flares, they used steroid prescriptions. So it's really hard to estimate fertility from a database is kind of what I'm getting at. But this is the best that we have. And this is a little difficult to understand, but basically people with disease activity, with disease and disease activity were less fertile. They had fewer live births. And this was true for all types of surgery as well. They didn't separate out the Crohn's surgeries and the ulcerative colitis surgeries. And they didn't look at time to pregnancy. time to pregnancy, how long it took someone to get pregnant. Because people with IBD, we're doing a study like this now, have increased time to pregnancy. And they didn't look at voluntary childlessness either, which is 17%, right, in women, about. So this is a beautiful picture of an ileal pouch anal anastomosis, which you guys do tons of. And this is the old studies in terms of fertility after open surgery. This is a meta-analysis by Welch. You guys all know this paper. It's old by now, but women have open surgery. I don't know if you guys do open surgery anymore, I don't think, but it showed a 2 to 3-fold increased risk of infertility with a significant fertility reduction. But these are newer surgeries, and laparoscopic surgery does make a difference. And I'd be curious to know what your results here have been in terms of fertility with laparoscopic surgery, being one of the huge centers that does it, I'm sure. So this is a cross-sectional study from the Netherlands and Belgium, 27 laparoscopic versus 23 open, with, again, a shorter time to pregnancy. So that's a good correlation of fertility. This is a French study that also looked good. So it's improved with laparoscopic surgery. We know that. And our surgeons are beginning to do it more and more for J pouches. So when do you...
Is a pouch different in its effects of fertility from an APR than an abdominal?
There's never been any comparison, but they're all kind of lumped together. But for ileostomies and APRs, there's like 1 or 2 studies, and the fertility is bad. It's bad, such that if I have patients who have severe perianal disease, I encourage like a subtotal colectomy to leave a Hartman in when they want to have their babies. We never let the rectum be removed. So it's probably lower than a J pouch, lower fertility than a J pouch.
Right, so
if you remove the rectum and anus. No.
That's the point. It's the
No.
pelvic.
It's the pelvic surgery, it's adhesions, it's scarring of the fallopian tubes, and it's very key. I mean, if women want to have babies, some people don't want to do IVF for religious reasons. So I've had patients for religious reasons didn't want IVF, but I didn't know. So, yeah.
It's interesting. Just to comment and then a question for you. The way I've always thought of this is I don't use fertility and fecundity
Right. Right.
equivalent, and so I want your comment on
Right.
that. The second is I read those studies about laparoscopic versus open, and all the pouches that I've ever sat through when I discussed it with my surgeons, the pelvic dissection is not fundamentally different with laparoscopic approaches as opposed to open. It's still a mess, and it's the neural damage and the scarring that takes place. How do you explain the difference between the laparoscopic and the open group, given that the part of the surgery that's probably most going to impact the patient's fecundity is essentially the same?
Yeah, I mean, that's a really good point.
It's actually technically different. The visualization is much better through the laparoscope. And there's actually an attempt to stay closer to the rectum during the dissection, so as not to interfere with pelvic nerves. So that would explain.
It can also be patients are healthier going into surgery now because we have better drugs. So maybe more recent studies.
Right, but also you choose, someone you're going to do a laparoscopic approach on may be very different than somebody
Right.
you're doing open on.
Right, that's
They
true.
only had, 50 some odd patients.
That's true. So in terms of fertility versus fecundity, I've asked so many people about this. I haven't really gotten a straight answer. Fertility, people consider everything that results in a live pregnancy, including voluntary childlessness, desire to have kids, birth, everything, to give you a live child. Whereas fecundity is just the natural biological ability to have a child. But there's not really a great distinction.
I just like saying fecundity.
I know. But in all the early studies, it's a good word. Yeah. In all the early studies, the J-pouch study, they all use fecundity, the ability to have a child, the biological ability to have a child. Fertility, I think, encompasses more. Yeah.
So the fecundity, how specifically, quantitatively defined the studies that have been published? I've seen several. I mean, one that was the original one that scared everyone was ability to have a child as per the number of attempts, right? Which is that how it's strictly defined? How good is the information that is
I think it's very hard to measure fecundity. I think the information is not good at all. And I think fecundity implies that you're trying every month. The ability to have a child as long as you're trying every month. But I think the information is not good, and fertility and fecundity are very hard to measure. I mean, how do you measure? You need a prospective study. And you have to, ask people using birth control, are you trying every month? What's your disease activity like? It's a huge prospective study. And to look back in a database is just very difficult. We have a Danish national birth cohort that we're looking at now that measures time to pregnancy. But again, the result is always a live birth. All the women had babies. But you can look at time to pregnancy as a measure of fertility. And it's fertility, right? Because it encompasses all other factors too.
Are you recommending that women freeze their eggs before?
Oh God, that's so funny. It's the first time I heard that was from Uma Mahadavid. I was like, I never, no. But this whole IVF thing, like a few women have told me they won't do it for religious reasons. I mean, maybe I would have them freeze embryos. Oh no. No.
Their own eggs.
Oh. It's so funny because I've never ever thought of it.
We've also had some men before the pouch construction asked whether they should donate sperm.
Right.
I have no one who's actually gone that far, and frankly, I think it's a very good question, probably a good option, but that's something you should probably think about too.
Yeah. I think there's no data.
I had several, again, they've been bringing it up more recently, but I remember 10 years ago, that was a big question.
Yeah. No, sorry, I misspoke. In terms of saving eggs or, embryos before surgery, I mean, the ovaries are normal. You should get healthy eggs after surgery. That's not the issue. The issue is a tubal issue. Yeah. I mean, there's no issue, like we've said multiple people for IVF after multiple surgeries, and it's not an issue of egg stimulation. I mean, ovarian stimulation. That doesn't affect surgery doesn't affect the ovaries. It's the tubes, the scar. Yeah, the tubes are totally scarred. Yeah. So anyway, when should you refer for assisted reproduction? We give it a year, or anybody who's had surgery with irregular cycles. Or we wait 3 cycles. The guidelines say 6 cycles on a patient who's had a proctectomy, an ostomy, or ileoanal pouch. So I do want to talk a little, if I have time, about our ART studies, assisted reproductive technology. So we did some Boston studies. That was some of the preliminary research, and then we did some register-based studies from Denmark. And we looked at Denmark is incredible. It has an IVF registry, so everybody in Denmark gets 3 free fresh cycles of IVF, and then an unlimited number of frozen cycles up to the age of 40, funded by the government. So they also get free abortions up to 12 weeks, by the way, no questions asked, in a hospital. Denmark's an awesome place. But anyway, so this is the IVF registry that we looked at. All women with Crohn's and UC, which we linked to with the CPR number. And we looked at live birth per cycle, per treatment cycle. Secondary outcome was adverse birth outcomes. So of course you have to control for a lot of factors. These, I'm not going to bore you by reading them. Social factors, demographic factors, calendar year, etc. But this is the upshot. So this is women with UC who had assisted reproduction, IVF, compared to women in the general population did worse with ART, had a less chance of a live birth, and that's here, the 2 adjusted numbers. So the odds ratio was lower. And this was the same for women with Crohn's. So women with IBD do less well with assisted reproduction, in Denmark at least. And if you look at women with Crohn's versus women with Crohn's plus Crohn's surgery, the women with surgery do even worse. And I think Crohn's surgery is going to be the same result for fertility. They're going to have the worst fertility somehow, when we've been looking at the Danish birth cohort too, in time to pregnancy. And we also found, and this kind of goes along with other studies of colitis in pregnancy, because colitis tends to get worse in pregnancy, and women with colitis tend to have worse birth outcomes, but women had increased preterm births as well if they had ulcerative colitis. So where along the process is the risk decreased? Why do women do so poorly? is a reduced chance of a live birth due to a chance of conceiving, a chance of embryo implantation? Are there some factors involved there? Or is it a problem with maintaining the fetus throughout the pregnancy? So we looked at, as an outcome, clinical pregnancy, positive ultrasound or positive HCG, okay? And then live birth. And we found that the trouble was with attaining a clinical pregnancy. So women, the embryo didn't implant. There was no clinical pregnancy in women with Crohn's and colitis. But there was no trouble from there to the live birth. So the trouble was somehow had to do with fertility. It comes back to this fertility question again. So why? Are there altered reproductive hormone levels in women with IBD? Is it the technique? Should it be different in women with IBD? Is there subclinical disease? Because the docs in Denmark say that everybody's in remission before their IVF cycles. Everybody's in remission, you know. Microbiome changes, autoimmunity, or meds, which I doubt, because there's some studies giving Humira to make IVF more effective.
Do we know if anything specifically about the egg and the embryo that makes it harder to implant, rather than anything to do with the actual?
That's interesting.
Like if you take, I mean, I guess no one has ever done this, but taking an IBD patient's egg and implanted, imagine in a non-IBD patient, would you be able to more obtain clinical pregnancy?
We don't know.
I'm sure no one has tested.
But there is a doc in Denmark doing research on uterine factors. There's a doc doing research on uterine factors in IBD women and non-IBD women. We don't know.
Getting back to the author of reproductive hormone levels, have there been studies on menstrual cycles, women with active disease, regular ways of rating of the activity disease? They measure gonadotropins molecular studies because that may be playing a major role in terms of fertility. Just simply getting a history of regular menstrual periods would be very important. Because we know in many other situations, from anorectics to female athletes, that the gonadotropins hormone falls themselves. You don't make follicle stimulating hormone, they don't make estrogens, they don't make eggs. So it's a simple study.
It is.
Menstrual cycle.
Yeah, I don't.
Are they function?
Yeah, not that I know of.
Well, interesting.
Yeah.
I'm just thinking.
It is. It's an excellent idea.
How often you can.
Yeah.
I mean, it would be a very easy way to just get some idea of whether, and then you can also measure the hormones.
Right. Measure the hormones. That'd be key. Yeah, that's excellent. Yeah. I don't know. I don't know the answer to that.
Other chronic diseases.
Oh. Oh. So we're looking at that too.
Kidney disease,
Yeah.
arthritis,
Yeah. Chronic disease. So
diabetes.
yeah. So women with RA do worse. There's a paper now, and women with thyroid disease do worse with IVF. And I think, my colleague is going to look at MS as well. But yes, it's across the board.
It's across
Chronic autoimmune diseases. I don't know if it's chronic disease. I know it's chronic autoimmune disease at least. So the conclusion is decreased fertility in IBD is due to voluntary childlessness, surgery, especially pouch surgery, and probably increased disease activity. Patients with Crohn's probably have decreased ovarian reserve. Laparoscopic surgery probably improves fertility. Women with UC have a higher risk of preterm birth with IVF. And these results suggest that compared to women without IBD receiving ART, women with UC and Crohn's have a reduced chance of conceiving, unfortunately. So the reduced chance of live birth is due to the stages of implantation, not the ability to maintain the fetus throughout pregnancy. And if we knew why, I mean, it would be fantastic, but I'm trying to work on it. So I want to thank you very, very much for having me here, and I want to thank my colleagues at Brigham and in Denmark, especially Bente Nørgaard in Denmark. And you guys remember Ray?
Oh, yeah. She's still alive.
I think so, yeah. Oh, yeah?
She's happy.
Isn't that awesome? Yeah. So, thank you.
That's really great.
Thank you.
Sonia.
Thank you.
And what questions? Jim George.
Jim.
A woman came in yesterday, and you had touched on it briefly, with newly diagnosed Crohn's disease with enormous elephant ears, just enormous tags, just huge. No fistula, no abscess, but these enormous tags.
Were they big?
No, they were.
How big were they?
They were not big, they were enormous. And they were clearly inflamed, and she said to me, can I have a vaginal delivery? So I want you to comment on,
You know, the problem is if she tears, which most people do, she needs an episiotomy, she can get poor wound healing. I mean, we do recommend C-section, but of course it's up to the patient, so it's more of a discussion. No fistulas or anything. I have had a woman with huge skin tags deliver vaginally and be fine and have no issues. It's usually the fistulas that people are worried about. So it's like, I can't give you a definitive answer.
Usher. What do you tell patients from C-section versus vaginal deliveries that had an uncomplicated J-patch?
I know. We tell them the risks with vaginal, which is incontinence over the years, and they make their own decision. Most people get C-sections, but we've been finding small, like ileuses after C-sections with J-patches lately.
Are there any databases, any real data on that?
No, not as far as I know. I think people are doing it, but I haven't seen any publications.
Ray's fine. She broke her
Oh,
leg.
good.
So she went
Good.
She's doing great. I just
Good.
spoke to her last week. I wanted your comment on, you touched on the phthalates in the delivery system for musical version of salamine a few years back.
Yeah.
And I was very frustrated with that particular chapter in pharmacologic history because many of our patients simply stopped taking their salamine because of that and then flared. And what I would like you to comment on what the genuine risk of phthalates in the concentrations that were found in these delivery systems, what sort of risk do you feel they actually pose to these women's pregnancies?
Yeah, it's low risk. It's low risk. It's not as high a risk as all the perfumes and shampoos and other plastic products that people use. The phthalate levels are a lot higher than those in Azocol and Azocol HD. It's probably very low risk.
But there is a risk, as I understood, especially in male offspring.
Yeah.
Hypospadias.
Yeah.
They measure, can actually measure, urethral distance, or there's a light that the reproductive people measure, and it's actually decreasing people in male offspring with high phthalate exposure.
I think men also have lower testosterone levels on Azocol too.
I have a question. Maybe David would mention. I distinctly recall that the azophagy alone, in the old days, they continuously reported hypospermia. I think we.
Yeah.
Absolutely.
Yeah.
Sure. So
Still.
that did not happen in phthalates.
No.
So it's a different issue.
Yes. So I remember that. So it may not. Did it have anything to do with
Motility.
Yeah, sperm motility.
And
It's like
also-
no, it's nothing to do with phthalates,
I'm sorry.
but well known.
So it's next.
You just mentioned that for anybody with, I imagine you're talking about perianal Crohn's, you recommend C-section. Is that for people who are in remission entirely?
So I don't want to say everybody with perianal Crohn's. People with active fistulas are the guidelines.
The elephant
It's
ears
iffy. I mean,
that
because
you were
if
describing,
she
that's
gets huge skin tags. If she gets an episiotomy, she could have poor healing. I mean, that's the issue. So you discuss it with them.
Even if they're in clinical endoscopic remission.
Yeah.
Steve.
So, congratulations on your beautiful collaboration with the
Thank
Danish
you.
group. I haven't followed the piano registry, but I believe there's many years now of following children born to women.
Yeah.
What do we know in the U.S. In terms of anything coming from the piano registry for some of these outcomes that you're looking at?
Yeah. I mean, we're really eager to see the results. They just haven't been published yet. When you speak one-on-one with Uma, she says everything's safe and it looks really good, but there's not been anything published.
Are they getting into Yale?
No, I'm sorry. Yeah. Isn't anti-TNF supposed to make babies smarter?
Only if they're in the crew.
Yeah.
If they're 6 years old. It's getting into depends on the parents.
So you touched earlier on speaking to your patients about raising eggs, and knowing that age is the largest contributor to decreased ovarian reserve, and knowing that these Crohn's women that are over 30 with the complexities of their disease, and they might need surgery at some point, they might have severe disease activity. Do you ever recommend that they freeze their eggs early on?
Let's just put it this way: Boston is like not New York or San Francisco. Like Uma was saying that everybody at Google, you can freeze your eggs for free at Google. I'm like, what? So like we didn't even think of it, honestly. It's like not something that crossed our minds to tell people to do.
Maybe I can ask the last question. So
Yeah.
the most important thing we can do is ask our patients about
Yeah.
sexual function. So what is your way to open that conversation?
Yeah.
How do you do it?
So how do I do it? I mean, there's been a lot of studies that have been done about sexual function. So how's it going? Do you have any problems with it? Because you can be helped by it. Just like kind of casual like that. People like, then it's a half an hour later, like tears. Yeah.
For men, there are 2 issues. There's libido, and then there's the actual physical function.
Yeah.
And there's a big difference. You have to be very careful
Yeah.
about that, because testosterone will increase libido. It has nothing to do with the mechanics.
Yeah.
So all these testosterone levels, in fact, if you give a lot of testosterone, you may actually decrease.
Like a lot of bodybuilders, right?
Yeah, absolutely.
That's why there's increasing infertility in men.
Not too much is known about that, and not too much is really.
Yeah.
You have to be able to really discuss specifics.
I think it's a really understudied field. It's a really understudied field.
It is.
Yeah.
Well, Sonia, thank you
Thank you so much. Thank you.